is a newly minted assistant professor of medicine and division of hematology and oncology at the University of Vermont Larner College of Medicine. She earned her PhD in nutrition from the Ohio State University with Dr. Martha Bellery and completed her postdoc training at the University of Vermont with Dr. Michael Toth. Her research examines how changes in adipose tissue, skeletal muscle, and metabolism contribute to cancer cachexia, particularly across the lung cancer continuum. Her work spans patient studies and preclinical models with the goal of identifying mechanisms and therapeutic targets for this debilitating condition. A particular highlight is her recent 5-year award from the U.S. National Cancer Institute, a highly competitive award that supports exceptional early career scientists as they establish independent cancer research programs. She has published extensively in cancer cachexia, body composition, and metabolic biology. So please join me in welcoming Dr. Deena Snoke.
Thank you. I just wanted to get that box off of the screen. Thank you for such a warm introduction. I'm really excited to be here and tell you a little bit about what I've been working on during my time as a postdoc for the past a little over 5 years. So today I have a few objectives. The first is to give you some background on cancer cachexia for those that are not familiar with this and our current understanding of body composition changes in patients, specifically with lung cancer. The second is to introduce our novel animal model of lung cancer cachexia and present some evidence that we have for early adipose wasting in this model. And then finally, I'll kind of come back to the human, to the bedside, and explore body composition changes prior to lung cancer diagnosis in patients. And then finally, I'll conclude and then talk a little bit about my future translational research program as I'm establishing my lab. So the space bar is working 50% of the time. So broadly, my work is focused on how cancer and its treatment cause metabolic dysfunction during the lung cancer progression. And so when we think about this, we kind of have to think about two different aspects of this. The first is the metabolic alterations that happen in the cancer itself. So this is going to be things like what's happening in the tumor environment, what's happening with metabolic reprogramming of cancer cells. But then also secondary to that, I know that this is near and dear to a lot of people in this room, what's happening with dysregulated tissue metabolism and endocrine dysfunction as a product of the presence of the tumor. But then, if we're thinking about humans, there's also other factors that we have to consider. So things like the genetics a patient has, right? How this makes therapies more or less effective, and how the therapies then affect the host tissues. But then also things like diet and physical activity as well. And so I really like to start with this because it gives us a more holistic kind of idea of all of the different factors we have to consider when we're thinking about human research. So today, the work that I'll be talking about is mainly focused on this idea of dysregulated tissue metabolism, and a little bit alluding into the cancer cell metabolic reprogramming area. But that's sort of where I'll be focused on today. So for those of you that are not familiar, cancer cachexia is the wasting of muscle and fat tissue during cancer. Clinically, it's defined as weight loss of more than 5% of the patient's body weight over the past 6 months. And so across all cancer types, about 40% of patients will present with cancer cachexia at their diagnosis, and this increases to about 80% of end-stage cancers. And so it's cited that about 20% of cancer-related deaths are thought to be attributed to cancer cachexia, and this is typically due to heart or respiratory failure because of muscle loss. So the diaphragm, the heart is not functioning properly. Importantly, in terms of what I'll be discussing today, the majority of lung cancer patients actually present with cancer cachexia. And importantly, despite the fact that this is clearly so prevalent, there are no effective therapies that have been discovered or developed that have proven to be effective in the clinic. So in our minds, there are two major limitations to this lack of kind of translation of effective therapies. And so the first is that it's very challenging to collect data on patients that are unwilling or unable to participate in research. And because of this, a lot of studies are often cross-sectional. And so there are challenges with capturing data in end-stage disease. What I mean by cross-sectional is that they take data from a certain time point and then predict for a mortality outcome or something like that. However, longitudinal data is more effective in telling us what might be happening in patients over time. And because of this, most of what we know is based on preclinical models, which have several flaws, and I'll be talking a little bit more about that today. So to come back to this idea, we really need to collect comprehensive longitudinal data on what's happening in patients. And so that's where my postdoc kind of started. And so I'm going to start here today. So my postdoc advisor, Dr. Toth, he has historically focused on skeletal muscle, and there hadn't been a study that looked at muscle longitudinally at the cellular level in patients with non-small cell lung cancer. And so that's what we set out to do. And so this really sets the stage for what I'll be talking about later. It might seem like a little bit of a digression, but I promise it will make more sense. So importantly, we wanted to see how whole body measures that are standard in the clinic corresponded with changes at the cellular level. So we recruited 11 patients for this study. And of course, it's quite invasive because we had to measure whole body, cellular, and subcellular measures of muscle health. And these 11 patients all had non-small cell lung cancer, which is about 80 to 90% of cancer cases for lung cancer patients. We also recruited 11 healthy controls that were matched by age, body weight, and biological sex. And so, like I said before, we compared these indices of whole body, whole muscle, and cellular measures of muscle atrophy in patients during their first cycle of treatment, and then again 2 months after treatment. And I do want to mention, and I discussed this with Arthur earlier, the small numbers of patients here are in part a function of, as many of you know, it's so challenging to collect invasive study data on patients that are really at the end stage of their cancer. But also we ran this study during COVID. So these patients were at high risk of infection. So it was really hard to get them into the clinic to do these measurements. And so, yes, we have a very small sample size, but the results were still very interesting. So in our patient population, 8 out of the 11 patients lost some body weight. And overall, our population was pre-cachectic, losing about 2.5% of their body weight over the last 6 months. These patients all had advanced stage cancer and were receiving at least one type of evidence-based therapy for treatment. So importantly, and very interestingly, we saw no changes at the whole body or whole muscle level by imaging, CT scan, DEXA, these gold standard measurements over this 2-month treatment period. However, when we looked at skeletal muscle architecture, we saw this really profound loss of muscle fiber cross-sectional area that's almost 20%. And this is just over 2 months of treatment for lung cancer. And this is across all fiber types. So just to set the stage and kind of look at some of the takeaways from this study, we saw that non-small cell lung cancer patients experienced this muscle fiber atrophy at the cellular level during treatment that was not evident using these standard non-invasive measures. And this could be due to things like fluid retention or other treatment-related body composition changes, or it just could be that muscle wasting is happening before we can measure it. And so that's a really important point to make. So I guess the major takeaway that we really want to think about as I'm talking about the work in the forthcoming slides is that we're missing important body composition changes in patients that have known prognostic value. So there's probably other things that are happening that we don't know have prognostic value as well. And importantly, it really emphasizes the difficulties in studying cachexia in patients that are unwilling or unable to participate in invasive research studies. So coming back to sort of this idea of longitudinal studies, our study is just one of several that highlight these challenges. And so there's actually very few studies that actually looked longitudinally at patients and measured some form of body composition. So I did this systematic review that pulled like 7,000 articles. We tried to intentionally make it very broad, and we actually were only able to identify 32 clinical studies that measured any changes in body composition using the listed methods. And all of the studies collected data during the treatment of the patients. So across these studies, we looked for some sort of consensus across, all of these patients with lung cancer, the majority of which also had non-small cell lung cancer. The majority of these studies do report muscle loss, so that's great. A lot of us study that. However, muscle loss was more pronounced in males and in male-enriched populations. And interestingly, only 35% of all of the study participants were women, despite the fact that there's about similar numbers of males and females that are diagnosed with lung cancer. We don't have to get into that. However, what we found is that actually only 11 out of these 32 studies reported anything about adiposity, and there was a lot of variation in what these papers reported. And so we sort of concluded that there's this potentially compartment-specific adaptation that's happening with different adipose depots, or this could be sex or disease stage specific. And the mean study size in this across these studies was 49. So it's very possible that we're not able to see some of these changes or look at stratifying data in certain ways to see if there's changes because the sample size is just simply not large enough. So the main takeaway here that's outlined in gold is that we really don't know anything about what's happening with fat. And then finally, I'll come back to this at the end of the talk, but no studies have assessed changes in body composition prior to when patients are diagnosed, independent of treatment. So everything that we know about body composition is during both cancer and its treatment. So we don't know the independent effect of cancer. We know that treatment independently does a lot based on preclinical models, and we know the same for the cancer, but in patients, it's a totally different story. So kind of putting this into a timeline of what we know that based on our clinical study and based on the systematic review that I published, that muscle wasting in advanced disease and over the course of patient treatment are very well described. One thing that's challenging to study that I brought up during the last slide is that it's difficult to study these patients before they're diagnosed with cancer. And so we looked at preclinical models to help us understand what might be happening to body composition earlier. So, we don't really know what's happening earlier on during disease. So before we talk about that, I just wanted to say, okay, well, wait, why should we even care about what's happening early on during cancer development? And so I wanted to give you some insight into what we're thinking about this. So we think that understanding changes in body composition, independent of treatment, might reveal ideas about metabolic reprogramming that's important for the development of aggressive tumors that leads to well-documented associations of cancer cachexia with poor treatment response, increased treatment toxicity, and increased metastatic disease. And so understanding these early events might reveal novel targets that could prevent muscle loss and growth. So coming back to this, as we've seen, there's some challenges in understanding this part of cancer cachexia in the context of the human condition. So a lot of what we know is informed by preclinical models about what might be happening earlier on. And so I'm going to walk you through the several flaws that are sort of major flaws of these currently existing models. And then I'm going to present the new model that we've developed and how we've sort of improved upon those flaws. So a lot of the models that are clinically or preclinically available advance too quickly to really understand what's happening with body composition over time. And I hope to illustrate that in the next couple of slides. So many of you are probably familiar with these models, but the Lewis lung carcinoma model is the most commonly used model of lung cancer. And so it's a model in which a bolus of tumor cells is injected into the flank of the mouse. And so basically what develops is this metastatic lesion that's just on the mouse's side. And those cells are not in their tissue of origin. They're not from the mouse. And so these animals advance to refractory disease over a 30-day period. And so at the time of their body weight loss, the tumor is a gram in weight before it starts causing body weight loss. So think about that. In a 25-gram mouse, you have a 1-gram tumor. And then once body weight loss starts, there's a 7-day window where we can measure changes in body composition. So that makes it very challenging to identify what's happening earlier, what's happening later during the disease development. So, So basically, what we've sort of come up with is that this Lewis lung carcinoma and C26 model is really giving us an idea of what's happening at the late stage as well, because it's happening so quickly that we can't identify early time points. And so a more protracted model would be more ideal to understand those relationships. And so I've also worked with the C26 models during my PhD, and so I know how challenging it is to, you have to measure body weight, food intake every single day and stuff like that while you're doing these experiments, because they just accelerate so quickly that it's so challenging to collect that sort of data. And so this is really just a model of late stage muscle wasting because that's what we can measure. So they're really telling us what's happening later on during the disease. And so my major point here is that we really don't know what happens early during cachexia and cancer development in the preclinical models or in the clinical setting. So that's really important. So the objective of our study was to develop and characterize a mouse model of lung cancer cachexia that better aligns with the physiological characteristics of the clinical syndrome so that we can identify early events and therapeutic targets. So going back to this model, you inject the bolus of tumor cells, it grows into this lesion on the side of the mouse. Our model, which is a lung epithelial cell specific to tamoxifen-inducible KRAS G12D mutation, they have tumors that develop in the lungs rather than just like not in their tissue of origin. So these mice are injected at 4 to 5 months of age. They get injected with tamoxifen, and then over the course of 12 weeks, they develop tumors. So to address this first point of prior models' flaws, the location of the tumors is much more similar to what a human with lung cancer would experience. I'd also like to just point out that, I'm selling our model a little bit. We also have a TD tomato tag engineered into the lung tumors, so we can do studies and look at things like tumor growth. You might be asking, okay, well, is a KRAS mutation important, or is it clinically relevant or significant in human lung cancer? And the answer is yes. KRAS is actually the most common mutation among lung cancers, and it's associated with more rapid weight loss. So you can see here that patients that have a KRAS mutation lose twice as much weight as those who do not. So next, the next thing that I mentioned is tumor burden, right? So I mentioned previously that these animals start losing weight only when the tumor is about 5% of the animal's body weight, and it ends up being like a gram in size. And so this simply does not occur in human patients. So when we looked at tumor burden in the lungs of our animals, at about 6 weeks, it's halfway through the model development, we see that the tumors take up about 10% of the lung area. And if we do a back of the envelope calculation, indicates that based on the average lung weight of a 25-gram mouse, this equates to less than 0.2% of the animal's body weight. So a little more similar to what humans would experience. So the next point is that there's this protracted time course of weight loss over 12 weeks. And so the LLC model develops over this 30-day period. And again, 10% body weight loss, 7 days. I'm hammering this home. So in our model, we don't see that accelerated body weight loss over the course of 1 week. Once the mice start losing weight, beginning at 3 weeks, we calculated the rate of decline of body weight, and it's less than 2% per week. And so this is much more similar to what a human would experience. This is also very valuable to us because it gives us an extended period where we can study the mechanisms of initiation of the tumor and cancer cachexia development, but then also an extended period of time that we could potentially test therapeutics. The final point here is that at first glance, looking at these two graphs on the left and right, these look very, very similar in terms of the progression. However, this is 3 weeks, right? By the time 3 weeks is up, these mice have lost more than 10% of their body mass. And at 3 weeks in our model, our mice have not even lost weight. So this comparison really illustrates the longevity of the model. So we have this protracted time course of weight loss over a 12-week period. So the first thing that we did was we wanted to characterize the end stage cachexia phenotype to make sure that this is similar to what others have reported in those preclinically used models like the LLC and cancer and C26 model. And so we looked at muscle, fat, and organ weight, and all of these contribute to weight loss at 12 weeks. However, it's pretty profound, the relative contribution of adipose loss to body weight loss. Additionally, I thought I'd throw some muscle data in here. So we see that, when we look at muscle fiber size of the excised gastroc and soleus muscles, we see that there's a very clear decrease in muscle fiber cross-sectional area. And we also see upregulation of ubiquitin ligases and Beclin-1 when we look at gene expression. So it's very much replicating what we see in other models of end-stage cachexia. And as well as it replicates what we see in the patients as well, which is really important. But coming back to the fat, what was really interesting to us was this profound loss of adipose tissue. So when we took out the subcutaneous and inguinal fat, so the subcutaneous fat is kind of on the side of the mouse, and then the perigonadal adipose tissue here in purple is like visceral fat in humans. We see that there's this profound loss of adipocyte cross-sectional area in both fat depots in the G12D mice compared to wild type. And so we also looked at glycerol levels. And so glycerol is a product of lipolysis. It's not reesterified. And so we can measure that in circulation and see if lipolysis is ongoing. And even at 12 weeks where this fat is mostly wasted, we still see elevated glycerol levels in the mice. So we were very curious, through these initial studies, we confirmed that at the late stage, these mice exhibit a classical cancer cachexia phenotype that we see in other preclinical models of cancer cachexia. So one of our main goals, as I've mentioned, is to understand what's happening earlier in the disease progression so that we can try and gain a better understanding of the changes that might be occurring early on in patients. And so we looked back to consider this time course of cancer cachexia development in these animals and decided to look at week 6 when body weight begins to decline. So right there. And so we did the same type of characterization studies. And at this early time point, we didn't observe any muscle loss at all. So we actually took out more muscles. The reviewers wanted to see more. So we took out all of the hind limb muscles. And we didn't see any changes in that. However, about 50% of the adipose had already been lost at this early time point, and this was due to decreased adipocyte size, as you can see in these images here. So like at 12 weeks, we also looked at the glycerol levels at 6 weeks during this kind of period of active adipose tissue loss, and we saw this elevation that's once again significant. And so we asked whether this was clinically relevant. We took the blood samples from our human clinical study that I presented in the introduction, and we actually saw there was also elevated glycerol in these patients with non-small cell lung cancer compared to healthy controls. And the reason I bring this up is we didn't see fat wasting in our human studies at the whole muscle, whole tissue, whole body level. Rather than, we didn't take a adipose tissue biopsy, obviously hindsight 2020, but our assessment of fat is probably like we found in muscle to be too insensitive to these small changes. And so we didn't really have the ability to look at fat cell size. So hopefully in our upcoming studies, we'll be able to get those fat biopsies as well. So going back to the mice, we also looked at a time course of development. So we looked at 3 weeks as well, and we see that the majority of fat loss is happening between weeks 3 and 6. And interestingly, when we look at tumor burden, it seems like there's an inverse relationship with fat loss and tumor burden that we didn't see with muscle. So that was particularly interesting to us. And so that started to make us think that fat wasting might be important for tumor growth. So to take this one step further, we wanted to look at the direct effects of tumors to incite adipose tissue wasting. And so we used in vitro modeling to do this. So we generated organoids from the lungs of healthy wild-type mice or lung tumor G12D mice. And, we did some basic RNA sequencing on these to show that they were in fact different, that they had the G12D mutation in KRAS. And so there's a number of genes that are up and down regulated, and we can see that there's a lot of pathways that we would expect to see upregulated in cancer. So we next took conditioned media from these organoids and we added it to the media of differentiated 323L1 adipocytes. And we saw that when we did that, we had elevated glycerol levels as well, similar to what we saw in the serum of our mice. So this was independent of the glycerol levels that was in the conditioned media. So that suggests that this is being produced by the adipocytes in culture in response to whatever's in that lung tumor conditioned media. So we've done a little bit of work exploring different pro-inflammatory tumor-derived factors that might be causing this lipolysis that we saw. We saw the direct effect. There's a historical perspective in the field that factors that are released from a tumor will affect wasting tissues. And so this has been studied pretty extensively, primarily in muscle. So we looked at some candidates that have been very well studied in the literature. So the first one we wanted to look at, of course, was IL-6. And interestingly, these mice have like no circulating IL-6. And even the mouse that had the highest IL-6, it was only 10 picograms per mil. This is in comparison to studies in LLC and C26 mice that have IL-6 levels in the hundreds, and sometimes it's even been reported in the thousands. So we're fairly certain that this may not be contributing. Interestingly, when we treat the adipocytes with our conditioned media from G12D lungs, we see that there is increased IL-6 in the G12D conditioned media, and this was independent of any change to IL-6 in the conditioned media itself, suggesting that the adipocytes are producing IL-6 in response to whatever's in that conditioned media. So to kind of tease this apart a little bit further, we added in IL-6 to our wild type conditioned media to see if we could then see an upregulation in glycerol release, and we did not. We added an anti-IL-6 antibody, and we also didn't see a very large decrease in the glycerol release. And so this suggests that this is not the initial stimulus that's driving the upregulation of IL-6, even if there is a modest decrease in the glycerol release when we quench that the IL-6 production. We also looked at GDF15, which has received some recent attention, and this was also not increased in serum, but it was increased when we treated cells with GDF or with the organoid conditioned media. And this actually was because there was an elevation in the conditioned media that's released from the tumor organoids. However, if we treat the cells alone with the amounts that were in the wild type or G12D conditioned media respectively, there's not a difference in the glycerol release. And so this suggests that this is probably not the factor that's causing it. We've also looked at HSP70, and again, we see that LPS, which is a canonical TLR4 agonist, does cause an upregulation of IL-6. It's sort of our positive control. But we also see that LPS treatment doesn't increase glycerol release in these cells either. And so that would be like the major shock to the system where we would expect to see something. As an aside, we didn't show HSP in that graph because the vehicle was glycerol, so we could not measure supernatant glycerol levels. So this kind of right now, right, the verdict is still out. So far, there's no classical mediators that seem to be driving lipolysis in our model. And so we have to remember that in these models, that have been previously studied, the tumors are non-physiological, they're very rapidly growing, and they're very different from our model. So this provides, opportunities to identify new potential mediators or targets in our model that haven't been identified before, which might have more translational success. So that's very exciting. We have a lot of work to do. So one other thing that we've looked at with this model is we asked whether, we can use this model to identify tumor mutations that increase susceptibility to cancer cachexia. And so a human tumor typically isn't just going to have one mutation. It's going to have multiple mutations. And so we wanted to know if we could potentially use this model to identify tumor mutations that would yield more rapidly progressive cancer cachexia. And so there's been some recent studies looking at STK11 or LKB1 loss of function in cells with mutated KRAS. And so this is a graph from Rodney Infante's group, but also Dr. Goncalves has also contributed to literature in this area using an IT adenocre model. But basically what they show is that when they add the KRAS or when they add STK11 to this cell line that already has KRAS mutated, and they transplant it into mice that are lacking a competent immune system, this accelerates cancer cachexia. And so we asked whether we could also, if our model was compatible with these findings. So we added in the STK11 loss of function to our model, again, having this TD tomato tag. And we see that, like we hope to see, that there's more rapid acceleration of this cancer cachexia phenotype. And now we're talking about the time period that, some of these other models see. However, you can see that the weight loss is very gradual. So one of the interesting things that we saw in this model, which was much more rapidly progressive, is that the distinguishing factor here is fat loss still. So we basically concluded that this STK11 loss of function predisposes to cancer cachexia, like others have reported. It also suggests that there's a utility of this model to examine lung tumor mutations that increase susceptibility to cancer cachexia, so we could test new mutations. And it also underscores that fat wasting is an early feature of KRAS-driven cancer cachexia in this lung cancer model. So in mice, we see that fat loss occurs early, inversely with tumor development, and that tumor-derived factors cause adipose tissue lipolysis in vitro, while muscle wasting only occurs after cachexia has been initiated. So I finally just wanted to sort of finish up, but I wanted to come back to this important point that I made earlier. No studies have assessed changes in body composition prior to patient diagnosis in humans. There's very little data that's out there to support this. You might recall that we didn't see any changes in adiposity in our study that we did with the very small study with 11 patients. And there might be challenges in capturing what's happening in adipose tissue. Because of its physiological function, adipose tissue is constantly remodeling, and so it might require a much larger data set to really see what's happening. So recent studies have come out to support that patients do lose fat mass prior to their diagnosis. And if this is correct, then our animal model really allows us to better see those changes. So this was a paper by Babik et al. That was published in 2022. And they show that prior to diagnosis in pancreatic cancer, patients lose twice as much fat as they do muscle. And additionally, there's evidence to suggest that patients diagnosed with lung cancer do experience body composition changes prior to diagnosis.
Like to Walmart or something.
So those reporting weight loss at diagnosis experience a significantly shorter mean
Okay, I got it.
survival time. than those who do not, and we can extrapolate that some of that mass is going to be fat. So a part of what we've done to understand the relevance of our preclinical work is ask whether early fat loss is clinically relevant in human lung cancer. And so around the time we were writing up this paper for Cell Reports, we developed a collaboration with a group at Vanderbilt that had previously used AI to calculate fat and muscle body composition from CT scans collected during the National Lung Screening Trial, which I'll discuss the details of in a minute. And so what they did was they looked at measures of body composition collected in patients prior to their diagnosis, and they showed that this predicted for patient mortality. Well, I've kind of hit home quite a bit that we're more interested in what's happening longitudinally rather than, a cross-sectional study where we're looking at one time point. This is useful, but it doesn't consider these longitudinal changes. And so we actually collaborated with this group to ask that question. And so on the right here, you can see an example of the data that they generated. And so they looked at the T5, T8, and T10 thoracic levels. And this is just a rendering of what was considered fat and muscle from the segmentation using AI, which I think is a pretty neat use. So we collaborated with them to ask this research question. And just to provide some background on the National Lung Screening Trial, this was a study that was done in the early 2000s, 2002 to 2004, in the US, and it recruited patients at high risk for lung cancer. And the purpose of this study was to look to see if CT scans were more effective at diagnosing lung cancer than X-rays. And we figured out that they were. So the study ended fairly quickly. It ended in like year 3. So we actually are most interested in this annual CT scan group, which is a large amount of patients that we could potentially pull data from. So what we did was we found patients that had more than 2 or more scans prior to their diagnosis. And we identified 436 detected cases. But then we also found controls that were, also participating in the study, but did not develop cancer over the same period. And so basically what we did was we were able to work with Dr. Tom Ahern, who's a biostatistician at University of Vermont, to developing a modeling approach. And what we did was we indexed the cases relative to the date of the patient's diagnosis, so that we could look at changes in tissue over time prior to the diagnosis. I also want to make an important point here that the thoracic cavity has some differences based on biological sex in the anatomical region of the scan. And because of this, we did not pool males and females together. They were separated from the beginning. So all of our studies were stratified by biological sex. So the data I'll be showing here is based on the average of the T5, T8, and T10 body composition. And we did look at each individual level, but it didn't change the results. So I'm showing the average. Interestingly, similar to what we saw in our preclinical model of lung cancer, females diagnosed with advanced disease experienced a loss of visceral adipose tissue, as you can see here. In up to 3 years prior to their diagnosis. And this is indexed to patient height to control for body size. And we also see a decrease in visceral adipose tissue density, which is what we would expect to see if the adipose compartment is shrinking and there's less fat. So to kind of put this into perspective, we also see that fat loss is an early feature of cancer in patients as well. So that was really a really exciting finding that tied all of this together and suggests that this preclinical model is potentially a very useful tool for people studying lung cancer and cancer cachexia. So finally, I just want to wrap things up and discuss the goals of my future translational research program. First of all, this novel preclinical model has provided us with a resource where we can better understand the temporal changes that are happening with body composition during lung cancer cachexia and the role that it plays in later stage muscle wasting. I also present, to what's our knowledge, the first evidence that patients with lung cancer experience body composition changes before they're diagnosed with cancer. So this is a very exciting finding for our group. Whoops. We hope that this work starts to get people thinking about the pathological mechanisms that are actually driving the disease, rather than sort of just assessing things that are happening at the end stages. There's this historical approach that I mentioned previously where we're really studying tumor-derived factors and honing in on identifying tumor-derived factors that cause tissue atrophy. However, I think we really need to zoom out and expand our perspective a little bit. And so we have some additional preliminary data to support the fact that maybe wasting adipose tissue feeds back and affects the growth of tumors. And so we're really interested in the possibility that there is a pathological importance of wasting adipose tissues to fuel both tumor growth and accelerate muscle wasting later during disease. And so this fits really nicely in with a lot of the tumor environment literature. There's a lot of studies that show that increased fat utilization is associated with things like tumor growth and metastasis. You know, of course, we're all very familiar with the Warburg hypothesis, but tumors really like fat too. So that is something interesting to consider. But not only that, but with kind of expanding this worldview a little bit, there's also opportunities to repurpose drugs that are used for other metabolic conditions. And so this might give some new opportunities to use drugs that have already been developed and see if they have a therapeutic use in lung cancer cachexia. So I just wanted to talk really quick about what we're currently working on. This is all published work, but my K99R00, which is the major career transition grant for PhDs in the US, is focused on building on this work. And so based on sort of this idea that there's this dual pathological importance of wasting adipose tissue, both in tumor growth and in muscle loss. And so, and then in the R00 portion of my award, I'm really interested in understanding how both endogenous fat from wasting adipose tissue and exogenous fat from the diet both intersect and affect sort of some of the similar outcomes. So this sets the stage for what I'm hoping will be a productive early career as I grow my lab. And so in conjunction with my K99R00 aims, I hope to contribute to understanding adipose-driven physiological events and understanding derived factors from tumors that promote lung tumor growth and muscle maladaptation, and understand some of the host-specific factors that I talked about on my first slide, so that we can position our field for clinical translation and really develop some drugs that are functional and work to improve outcomes for patients. And finally, of course, we want to identify and test novel metabolic targets during tumor growth and cancer cachexia. And of course, as you would if you stayed in academia and were a research and investigator, of course, I want to train empowered and capable scientists along the way. So I'm really excited to be starting this out, and I think we have a lot of great directions that we can go in. But I'm definitely open to discussing opportunities for collaboration and seeing how we can help each other out. And we're sending our mice places and people are using the model, so that's very exciting. I just want to give a couple of shout outs. Of course, members of my lab and my K99 committee. Mike has been the most incredible postdoc advisor I could ask for. When I came in and started a postdoc, I did not want to do what I'm doing. And so it completely changed my perspective. And so I'm very grateful for that opportunity and experience. Also, of course, members of my lab, my T32 and K99 committees, and all of the people that have helped with the publication of these studies as well. So here's my email. I would love to discuss collaboration opportunities and funding. These are my funding sources here. And I also want to put in a plug for Women in Cachexia. Follow us on Instagram. No, not Instagram, LinkedIn. Follow us on LinkedIn. There's some really great seminars coming up that I've been helping with organizing. So thank you for your time, and I am happy to answer any questions. Perfect timing.
Perfect timing. Great job as well. Thanks so much.
Thank you very much for the very nice to hear about the most students how they talk together and how they are doing to show up. From what you see is that to be indeed a big change in the metabolism with liver, spleen, adipose tissue muscle being the cancer type. You mentioned the Warburg effects. We know that in the Warburg hypothesis there is a lot of lactate production by the cells, in particular in the tumor environment. And from what you see in the shrink of the what shown in the shrink of the adipose cells, the size of the cells, do you think that it could be a change from white adipose to brown adipose tissue? This is in terms of lactate, and that would be also why you hint that there is this feedback of the adipose into the tumor growth.
So we've looked at beiging of white adipose tissue in the model. We've looked at it at the gene expression level. We've also stained for UCP1, and we don't see differences in beiging, which is interesting. But also there's very little clinical data to back up the fact that that could be happening in patients as well. The question about the lactate.
Yeah, I mean, because we know that, I mean, there are evidences showing that influx of lactate into the white adipose tissue can trigger
Okay.
or transformation to beige.
Yeah, we haven't measured that, but it's a good point, and I definitely will look into that a little bit. Thank you.
Very nice talk.
Thank you.
So I have two short questions. First one is, does your Crafts model exhibit sex differences?
So right now, we stratify all of our analyses by sex, and we have not seen major sex differences.
So it doesn't quite resemble the human type.
So it could be that there's sex differences, but it could also be that females also just have more fat in this area, which is very likely. And so we can see the changes easier. There are also more females in the study that we were able to identify that had more than one scan. So there could be multiple reasons that explain that. So we're not, 100% sure that it is a sex difference that we're seeing, but definitely of interest for sure. Yeah.
My second question was related to the glycerol mystery that you
Mhm.
I immediately thought catecholamines when I saw the glycerol elevated in the in vivo model.
Yes.
They elevated, but then your in vitro stuff, it's unlikely that adipose tissue is producing catecholamines. But beta adrenergic pathway is what causes lipolysis.
Right.
Are any of the growth factors acting through that pathway that we're testing?
So we have not looked into that, but it is of particular interest. Yes. Yeah.
Thank you.
You hit the nail on the head.
Awesome talk. Thinking about the body physiological mechanisms to regulate the reduction in adipose mass and the induction of lipolysis. In a healthy state, if any organ needs more glucose, takes glucose out of the blood, you have sensitive mechanisms for the pancreas, liver, brain to now activate lipolysis to support gluconeogenesis in the liver to store glucose.
Yeah.
So what if it's not a pathological signal from the tumor per se to adipose that's driving the lipolysis? What if it's just another glucose user? Has anyone looked at whether liver gluconeogenesis, particularly using fat amino acids, whether liver gluconeogenesis is upregulated at the time that adipose lipolysis is?
So we've looked at some markers of that with gene expression, and we actually see that liver is dysregulated only after the adipose loss starts to happen.
So that would be the RNA level. Has anyone ever done?
We've measured
with adipose-derived fatty acid tracers going to the liver and monitoring tracer tags on glucose coming back from the blood?
I think you can definitely do that. We have not. It's definitely something that we are proposing. That Mike is proposing going forward. We have measured 24-hour fasting beta hydroxybutyrate, and we see that the ketogenesis is impaired in the liver. But that's like later, so it's after the initiation.
Right.
And we see that there's some alterations, like the glucose is lower, but that also corresponds with what was recently published about increased glucose and like increased insulin sensitivity in cachexia. So that also corresponds with what other people are seeing.
That's exactly it.
Yeah.
That increased insulin sensitivity is indicative, I was gonna say suggestive, indicative of, also indicative of a heightened demand for glucose.
Yes.
And so,
Yep.
yeah, full circle. And I was
Yeah.
kind of wondering, if I could sneak in a second question, if your model shows metastasis.
So so in order to look for metastasis for all of you, you have to like section every single tissue and look for fluorescent cells. We have not done that. That being said, we don't see
No,
tumors.
you don't see it visible. Which is the method we've done, is a photograph, which isn't foolproof. Yeah,
Yeah.
but presumably in humans, it metastasizes at certain stages, or
So yeah, so I mean, stage 4 would be metastatic disease, right? So the patients that we were working with, for example,
Yeah.
you know, a good amount of them had metastatic disease. Typically metastasis in lung cancer goes to the lymph nodes. So we did in our last group of experiments, we dissected out the mediastinal lymph node, and we are going to be looking at those to see, you know, as like a first location of metastasis at the late stage, whether there is metastasis there. And then that might lead to, you know, going down the rabbit hole a little bit further.
and that's really interesting, because this strongly suggests then that the reduction in adipose mass is preceding, probably preceding metastasis. In our ovarian cancer model, we don't see muscle wasting until metastasis occurs. And now I gotta go back and look at our adipose tissue graph. I have a funny feeling the adipose was declining before metastasis, unlike the muscle.
Yeah.
And if you aren't visibly seeing tumors elsewhere in the body, the breast or half, that's probably meaning that there's not metastasis. At the time you're making the measures, then you really have a pre-metastatic condition that might align with that particular population, so, as opposed to what changes are occurring in adipose. To what degree of metastasis contributing to adipose atrophy is what I'm
Yeah.
getting at.
Yeah, that's a really good point.
Just it's not.
Mm-hmm.
It's actually really
Mm-hmm.
pretty interesting.
Yeah, we kind of think that there's this pathological importance in that, like, adipose loss is providing the tumor with something that it needs to become more aggressive, basically.
Thank you.
Yes.
Okay,
Oh.
go ahead.
So if I was looking at it pessimistically, obesity or at least excess of fat tissue is correlated with increased rate of cancer. You're showing that loss of fat currently is a clinical sign of appearance of cancer. What becomes?
So
Is it good to lose it, or is it good to keep it?
I think about this a lot, actually. So the way that I think about this is that some of these cancers that are associated with, you know, increased body mass and increased adiposity have more available fat that could be released. And so that's sort of the way that I'm thinking about it, if that's helpful. But yeah, it is a bit of a conundrum, I will say. So it's something that I do think about a lot. And obviously there are some types of cancer there's this obesity, what is it? It's like an obesity conundrum or whatever, where some cancers are actually protective against, or obesity is protective against cachexia development. And that just might be because they have more mass to lose, right? So they could be, the same things could be happening, but we're not seeing it because it's masked by, you know, fast changes in and out of adipose tissue, or things that we can't measure using these conventional measures, which kind of goes back to the problems that I described earlier. Yeah, that's a great point.
dumb question. Have you ever considered what would happen if you reduce caloric intake towards the later stages? Because usually when lung cancer patients get diagnosed, like your side said, it's usually at stage 3 and 4, so it's already progressed so far. But one of the commonalities when they have like chemo and radiation with pharmaceutical interventions, they drop weight significantly, and a lot of them have trouble even maintaining like the basic normal caloric intake.
Mhm.
Do you find that that would then exacerbate and contribute?
Yeah, so we have measured food intake in these mice. The G12D mice don't have, so historically in the literature, it's been shown that in these C26 and LSE models, they reduce their caloric intake because they're sick, right? Which is what we expect. We see it at the very late stages. And so that's expected, but they already are reducing their caloric intake at the late stage. We haven't withheld food from the mice. We've done some fasting studies where we can look at BHB and we track the recovery of body weight over the short, or it's a long fasting period for the mice, it's 24 hours. But we haven't done like an extended restriction of calories. But that's a good point.
Adam, we have a question on.
Yes, so there's a question on single shards answer. So thank you for your presentation. Did you notice whether skeletal muscle loss tended to occur after adipose tissue has lost, or as loss has plateaued? She's wondering whether ongoing adipose tissue loss might help provide substrates, examples of liposphilic lipogenesis. That spare skeletal muscle with muscle loss being more pronounced once adipose tissue loss plateaus.
That's the idea. So yes, so there's sort of this, people focus on muscle not only because it leads to faster decline in patients when they have muscle loss and weakness, and that it's sort of the main cause of the cachexia associated death, but it also provides these gluconeogenic substrates for the tumor. And so based on the Warburg hypothesis, that makes sense, right? But it could be that the tumor is using fat earlier and then switches to glucose later. So she's on the right track. They're on the right track in what they're describing. I would agree.
Have you considered screening the serum
For what?
to find out what's different and what could be causing that increase in cholesterol?
Yes, so we've done some metabolomics. Nothing. We have a lot of data to sort through.
Okay.
But yeah, so we've obviously done, a Luminex assay where we've looked at a bunch of different factors, and we don't see that anything that could be a candidate mediator based on what we know has been identified. We've also done some studies where we're looking at extracellular vesicles in the conditioned media. Some interesting results with that to be TBD. But yeah, it's an excellent question. So
nothing obvious.
yeah,
Yeah.
no.
Interesting.
So
All right. Well, thank you very much.
thank you. And thank you all for coming.
Thank you, everyone.